Now, you were all expecting Jeremy Hunt this afternoon, but obviously because you jinxed us, we can't do that. So if I can ask our next speakers to come up to the stage, we have an interesting session this afternoon. We're going to have a conversation with Sir Bruce Keogh, former NHS England Medical Director, and Dr. Aidan Fowler, who's the Patient Safety Director in Wales, leading the 1,000 Lives Improvement Project. And we're going to have a quick chat with them about safety and where we go next. And obviously we'll be looking for some input from you guys as well. If I can ask you two to join me on the stage, please. Please welcome them, because they're helping us out this afternoon.
After you, Aidan.
Obviously, Jeremy Hunt was too cowardly to come on stage with me. He's engineered a whole government crisis to avoid it. But these guys are braver, so thank you very much, gentlemen. Bruce, if I could maybe just start with you. You've had years of experience working in the NHS, both at a very senior level and obviously starting out as a junior doctor and a medical student. In that time, give us perhaps your reflections on where we've come from on safety.
I think we've come quite a long way, actually, Sean. My first interest in safety started when I was a medical student. Sorry, my phone is ringing. It's Jeremy Hunt. Says, don't say that.
No, to be Matt Hancock now.
Started when I was a medical student. I was doing obstetrics. And I'll say the name of the hospital at Northwick Park. I remember the name of the consultant. And I didn't like what I saw. And I pointed this out to the consultant. We had a disagreement. I was reported to the dean. I had to go and see the dean of the medical school. And I said to him, you need to withdraw medical students from that obstetric unit, put them somewhere else. I said, it's like an abattoir. And that evoked some kind of response. But the response was, look, you've only got a few months, just lie low, pass your exams. And nothing changed. And then if I fast forward, so that must have been about 1979. If I fast forward to somewhere around 2004, and I was on the board of the Healthcare Commission, it was the first time that regulatory powers were ever used to force improvement on a unit. And I just hope that it had gone through a cyclical phase of improving. But that set me wondering about how we bottle the word on the street when things aren't going well. And similarly, when I was an SHO, I was working at the Hammersmith Hospital in London. No, sorry, I was a registrar. I wanted to go to another registrar job in Bristol. This was in cardiac surgery. All the other registrars said to me, they said, no, whatever you do, do not go to Bristol. It'll kill your career. And that was 10 years before the Bristol Royal Infirmary inquiry. So one of the things that I've grappled with and haven't been able to solve, maybe others can, is how you bottle the word on the street. Because if you wait for the indicators and the data to change, you've kind of, you haven't missed the boat, but you haven't tackled things as early as you should.
And there's not a scandal that we haven't discussed at the Congress this year, from Gosport, Midstaffs, Morecambe Bay, and all the others, probably going all the way back to Ely Hospital in 1967, where there wasn't a signal in the system. And I mean, Aidan, can I ask, is Bruce right there? We need to find a way to spot those signals that are coming through?
Yeah, I think that's true. I mean, I wasn't a medical student in 1979, just to point that out.
Were you ever?
Was I ever? I think it's very difficult, and I was listening with great interest to Bill earlier and thinking about the concept of plaiting fog to make something strong enough to get hold of. And these cases we hear in the news are not alone, and we hear individual smaller cases from wider afield where, with hindsight, which is a great thing, there was a signal that we didn't pick up. But I've also had the experience of being in the position of managing a surgical unit where there was noise, and you just can't get hold of enough, because there are processes, and rightly so, to protect staff. You can't get enough to actually act. And people are very reluctant to come forward. I mean, I can think of an issue where a number of anaesthetists came to me and said there is a problem with an anaesthetist, that they've done something that is below standard, there was a near miss, the patient could have died. And yet, when we then acted, those people stepped back and were very reluctant to speak. They were very reluctant to speak openly in public about that. They're very reluctant to confront. And I think what we hear on the news is that the system closes ranks, and that may or may not be true, but I think people are frightened of the conflict, they're frightened of the process, the fact that they'll get into something that becomes adversarial, and that it will take up their time for some time. So I think there are two issues. What's the signal? How do we pick that up? How do we act on these soft signals, if you like? I mean, Bill mentioned rumours. Well, what can you do with rumours? So how can we get the whole picture rather than just individuals getting part of it? And then how can we get better at those processes of managing people in that situation so that it's not so frightening for people to get involved in?
And Bruce, I wanted to ask you, because I remember you acting on a signal, perhaps, I don't know if that's the right description, correct me if I'm wrong, but you did intervene with Leeds Hospital around the congenital heart issues and mortality there, and it wasn't exactly an easy process for you, was it? Just talk us through that, if you wouldn't mind.
Yeah, I'll give you the short version. But it was 2013, a couple of weeks just before Easter, and there were a couple of things that were going through my mind. One was that when Bristol was starting to emerge, people spent a lot of time arguing about the data, while meantime bad things were happening. It was the same with the HSMRs and mid-staffs and one or two other places. And so I got a phone call. The background to this was that there was a review of children's heart surgery going on, and Leeds felt that they were going to be closed. So things were very febrile and sensitive. I got a phone call from a senior pediatric cardiac surgeon who was actually working at the Birmingham Children's Hospital at the time, widely regarded as the best congenital heart surgeon in Europe. And he said, look, he said, there's something funny going on in Leeds. He said, Kevin Watterson, who's a senior surgeon, he said he's away on holiday. The place has been run by 2 locums, and the 4th surgeon has been suspended. And he said, there's a long weekend coming up, and you need to speak to a guy in Newcastle who's very worried about it. So I said, well, get him to ring me. So the senior pediatric surgeon in Newcastle rang me and said, there are problems, and I'm picking up some of the pieces. And I said to him, look, Asif, I said, I can protect your anonymity a bit, but you're not just speaking to me as an old friend. I said, when you speak to me with an allegation like this, I cannot do nothing. And I was busy thinking about it, and our office was in Leeds at the time. I knew the surgeons in Leeds, they were friends, you know. And I got a phone call from Roger Boyle, who I would regard as one of the best national clinical directors we've ever had. And he was beside himself. He said, you've got to do something. You've got to do something. And eventually he said, I've seen data which shows that the mortality for children's heart surgery in Leeds, partially risk adjusted, is, I think it was 2.5 or 2.7 times above the national average. So there's clear blue water between them and the others. And so I thought, I've now had some warning signs. It's time the NHS got to a place where we took preemptive action. So I spoke to senior colleagues in the NHS and said, I can't do nothing. And so on Monday, Thursday, I went to Leeds General Infirmary, met with the medical director, the chairman of the trust, and the chief executive. It was about 7:30 in the morning, and said, I've got this data, is it true? Now, they were busy looking at their cardiac surgery data. And they said, cut a long story short, what do you think we should do? I said, well, I think you should suspend your surgical activity until you know whether this is real or not. And the children's heart surgery national figures were run out of Leeds. So one would have expected their figures and their data to be good. And I said, look, you've got a long weekend coming up. I said, we can transfer all the emergencies elsewhere. you can look at stuff over the weekend, and by Tuesday, you'll know whether you can be up and running or not. And they said, well, no, it'll take us 2 weeks. Well, that rang an alarm bell, because I used to run a national audit, and it should take you hours, not 2 weeks. So then they said, what authority do you have to stop us doing surgery? I said, I have absolutely none. Actually, it was just in the period between the Department of Health and NHS England, and we would have had the authority on Saturday, but now was Thursday. And I said, but if it ever came out that you'd met with me, I've got an international reputation in outcomes measurement in cardiac surgery. I'm medical director of the NHS, about to be medical director of NHS England. And I've run the national database for many years on this kind of stuff and advised on setting up on outcome measurement across the globe. I said, it wouldn't look very smart if you hadn't taken my advice. And I said, as far as I'm concerned, this meeting's never happened. I'll leave here. You've got your board meeting, decide what you're going to do. And I walked back to my office. Well, by the time I got there, it was already on the BBC News. And I learned quite a bit from that. One is that, you have meetings, everybody knows about them. There was a lot of political interest, is probably the best way of putting it, because I hadn't warned any political colleagues that I was going to do this. There were allegations that I was simply trying to close leads, which is nothing further from the truth. But it's, when people form a view, you can't change it that easily. There were 2 debates in the House of Commons about my behavior. There were all sorts of things that went on. I was due to be going as a visiting professor to Japan that weekend, and I went off, but I got called back to deal with some of the flack. And so it was the right thing to do, and I would do it again.
That was what I was just going to ask you, yeah.
Absolutely the right thing to do. And it wasn't popular, but imagine the scenario that one of those 2 locums, that something had gone wrong, a very complex patient had come in and died. And I had known that there was a 2.5 or 2.7 times elevated mortality. And I had done nothing. I would have had to resign. And then when they did analyze the figures, they found that it was their data. They had 4 times as much missing data in their data submission than any other.
Key is they didn't know that at the time, though, did they?
They didn't, and they should have, because they were running the show.
Yeah.
They were responsible for all the data in the country.
Aidan, obviously you've been patient safety director in Wales for a few years now, running the 1,000 Lives program. You've built a whole process there, but do you recognise the same challenges that Bruce is talking about there from your experiences in Wales, and could you tell us a little bit about the work you've done in Wales?
Yeah, I mean, I haven't found myself in a situation like that in Wales, but the case I was talking about, that was the pressure. The decision was to stop somebody working unsupervised, and what I had to sit there and think was, I would rather take the flak, and I had surgeons coming at me saying how unreasonable I was, and I had anaesthetists coming at me saying the same, than ever have to stand up in a coroner's court and say I could have done something that would have prevented 1 death. So, I think for me it was quite clear, but it came at a cost, but it was the right thing to do again. Back to Wales. So, what have we been doing? So I think the first thing that I think is going to be different, so you didn't mention it at the start, but I think a lot of people know that I'm moving next week to England as National Patient Safety Director. In Wales, the job is National Director of Patient Safety and Quality Improvement, and I don't see that patient safety isn't part of quality improvement, and I think sometimes it's seen as separate. It's not. And I think there's a lot of learning from the process we've been going through there to make sure that we have the capacity and capability to do the work first, so a structure, if you like, to do it. And there's a lot, obviously, to build on in England. So I'm coming in to try and see where the opportunity is to improve on what's already there. And, of course, there will be the learning from what we've done in Wales. And one of the things we've done as a national body is get back to doing what a national body should do and not the small stuff that organizations are doing for themselves. So it's making sure we prioritize properly and do programs, and we've been rolling out programs across Wales in the things you would expect. So healthcare-associated infection. Those of you at the wards last night, we've been doing work on maternity, so one of which was postpartum hemorrhage. I think, are the girls here from Obs Cymru? There you go, stand up
waving
for us.
at the back.
I said I'd give them their moment, so they were at the ceremony last night, but you know, examples like that. So across the system, we've looked at measuring blood loss, and we're starting to get data showing that in one area, fresh frozen plasma transfusion's gone down from 5 units a month to 1. You know, across the system, that makes a big difference. There's other work, prompt, et cetera, et cetera. There's lots going on. And so it's getting back to that, recognizing that there's a lot of variation across the system, and some of it's warranted, a lot of it isn't warranted, and getting best practice across the system at national level where indicated.
And can I be cheeky, and seeing as you're only a few days away from your new job in England, can I ask you...
You promised you wouldn't be.
Can I ask you how you... I can't ask you what you're going to do because you haven't got in there yet, but I suppose we'll save that for the interview with HSJ that no doubt will follow. But how are you going to approach the job? Because I think that is almost as important as what you're actually going to do.
Bill earlier referred to William Osler. And he said, listen to the patient because they'll tell you the diagnosis. So the first thing I'm going to do is listen and find out what's going on, what's strong, and where the opportunities are. And there's a huge breadth of stakeholders, many of whom I've met here, who are already key players in the system, who I want to talk to and find out what they think is going on and get a sense of what's in the system and what's already there and what we could build upon. So listen first to get the diagnosis before the treatment. And then, you know, and it's this clinical parallel of, well, once we've decided what's going on, think about the treatment, but also we need to get better at earlier intervention. We've talked about that. How do we make a diagnosis earlier? Screening, if you like. And then how do we prevent? So the prevention approach of how do we stop these things happening in the first place. So yes, we need to get good at sorting out patient safety. We also need to get better at seeing when there's a safety problem earlier on, and we also need to get better at preventing safety issues in the first place. So there are a number of approaches.
I'm sure everyone in the room will wish you well with that. You can come back next year and tell us how you're getting on. Bruce, I think it's probably, I'm sure you won't mind me saying that you are obviously on your way out of the system on the national level. And clearly Aidan is coming in, fresh-faced and bushy-tailed and ready to get to work. What have you learned that might be useful for Aidan? What lessons could you pass to him here on the stage for us?
Okay. Before I answer that, can I just say something about Leeds? Because there'll be people in the audience here. They should be really proud of their children's heart surgery unit now. Whatever the issues were are resolved, and it's very, very good.
Fair point. Fair point.
So I suppose I came to the safety business. Liam Donaldson was the person that really put safety on the map. And I remember at one time he started talking about safety and not doing harm. And I was a practicing cardiac surgeon at the time, and I thought, you know, what's all this about? Do people think we go into work to try and do bad things? And I didn't quite get the safety agenda. But over the course of the last few years, I've realized that it is so big. And I think there's a global element to it, there's an international element to it, there's a national element, there's a regional element, an institutional element, and a personal element. And all of that impacts on the NHS. So to give you an example of the global element, one of the highest risks on the government's risk register at the moment is antimicrobial resistance. And that is a big global issue because we're running out of antibiotics. If things get really bad with resistance, it is, as Sally Davis puts, it's an apocalyptic scenario. So that is big, and that can only be dealt with at a global level, and the United Nations and World Health Organization people onto that. Then at an international level, there are things which impact on safety in the NHS. So the medical device regulations in the European Union will determine the safety of devices we put in. I was horrified, for example, when I was asked to look at PIP breast implants, to do an independent review of them, which were mainly put in the private sector, to find that they were regulated under a different set of regulations to medical devices. So they had about the same level of regulation as an electric toothbrush. And so there are things that can be done at an international level that are, I think are relevant. But it often introduces a delay for us. And then I was thinking, when I heard Keith Conradi talking today about font size on packaging. Well, that's also a kind of international thing. You can get companies to do different packaging for different countries. They do that because language varies. But if you can get them to see the wisdom of making change across the full spectrum of their products, whether they're selling them in Latin America or the United States or the UK or Europe, you have a better argument. And appealing to their kind of commercial sense in that arena is important. So those are the sorts of international things. At a national level, the spectrum of things which influence safety in our NHS is really quite enormous. It starts with security. I had a legal responsibility under the Civil Contingencies Act at one point to ensure that nobody came to harm during the junior doctors' strike, for example, at a time when emergency cover was being withdrawn. Similarly, there are other security considerations which come into play for the well-being of the citizens of this country and influence the way we the way that we dispatch our services according to prevailing risk levels. There are issues around the supply chain of drugs and devices into this country. So we know that many drugs are only made in one or two places in the world, often a long way away from Europe. And they have to cross a lot of countries to get to our country. And if there's an outbreak of flu or the price changes or there are problems getting the drugs to this country, we need contingency plans. Otherwise, people are at risk. And we've got quite good contingency plans, I think, for the pharmaceuticals which are entering this country. But some years ago, there was a problem with an earthquake in Italy. It was in August when the Italians have some time off. And we lost access to essential bits of renal dialysis kit. And it struck me then, this must have been about 2009, I guess, or 10. It struck me then that we didn't have the same level of contingency planning for our devices. So that the supply chain becomes really quite important. Then there are legislative issues about what structures do you put in place and the way the NHS operates. Safety is often not a high consideration in that. It's often driven by financial and organizational considerations. But legislation, things like HSIB, will make a big contribution. And I think their two early reports actually show that there's a deep grasp of the fundamental issues. Yeah. Tracking of devices is really important, so barcoding. But barcoding is kind of dependent on European legislation.
He's doing a whole shopping list here.
Yeah, I mean,
I'm going to take.
You're going to fix all this later, yes.
Targets are really important. So targets will have perverse incentives and good incentives, and what they change. So a target which is good in one set of 5 years may not be good in the next. So I think all of those kind of things are important. Then there are the regional levels. Ted Baker was talking about the barriers between institutions at a regional level, social services, providers adopting a kind of lager mentality between each other. Those are all safety issues, but they can be resolved at a regional level. And then people in this room will know much more about institutional and personal things over the course of the last couple of days. I won't go into those.
So Aidan, if you could get all that fixed by Tuesday, that would be...
No problem at all.
I wanted to ask both of you this question. I've been chairing this Congress for 2 days. We've heard reference to Morecambe Bay, Midstaff's, Gosport, Ely Hospital, all sorts of different reports and scandals that there have been over the history. And in the last 5 years, there certainly has been a flurry of big reports and lots of recommendations. And I just wanted to ask both of you, from your different perspectives, is it time that we had a bit of a stock take? We've got rid of Jeremy Hunt now, so we've got a new health secretary. Is it time that we stopped, paused, and looked at this and sort of maybe considered where are we, where have we come from, and where do we need to go?
I think the answer to that is yes. We don't yet know what our new Secretary of State for Health's priorities will be, but we can guarantee it will be providing good healthcare broadly. And I mean, I was here last night at the awards and saw the reaction to Jeremy Hunt's departure, but I would say he has put patient safety on the map, which for those of us in the room who are all passionate about it, it's not unhelpful. I think there has been a tendency to be reactive, and there are common themes amongst all those things you mention, and I think it would be wise for us to understand what some of those themes are and understand how a longer-term plan can influence that, rather than constantly expecting people to hop between one thing and another, which I suspect is not a great use of resource and not as productive as saying we have had a lot of events from which we can learn. Let's now look at the system and how we can plan better to reduce the chance of those occurring again.
Bruce?
I've had the benefit over the last decade of working with a number of different health secretaries. One thing that they all have in common, because I started pretty well the same week as Alan Johnson in the Department of Health, is they're very receptive when they come into new ideas. So you'll get an opportunity, I think, because they don't know about health. So they'll be seeking ideas from people that will give them a platform on which to develop their own political careers. So a stock take, in my view, is a good idea. I've given you a list of things. There's a longer list. But understanding who's responsible for what in that would be really helpful. And can I just make one last observation that's niggled at me? Must have been around about 2003. I was a cardiac surgeon in Birmingham. And my secretary said to me, she said, "Here, have you seen this stuff from the Department of Health?" Well, I never looked at stuff from the Department of Health. But she said, the Secretary of State wants to halve the amount of MRSA over the next 3 years. And I said to her, I said, "Geez, what are they smoking down there?" I said, "They just need to come and visit our ITU. They'll see, you know, immunosuppressed transplant patients. They'll see elderly people who've undergone really complex surgery. You know, MRSA and infection, this is the price you pay for the complexity of the service that we offer." And the two things that struck me about that is, firstly, I was wrong. And sometimes in the sorts of jobs that we do, it's really good to be wrong, but recognize it when you are. And the evidence that I was wrong was that in 2003-04, there were 7,700 reported cases of bloodborne MRSA. In 2014-15, there were 817, so there was a 90% drop, largely based on the things that we knew we could do to reduce infection that Ted Baker alluded to a few minutes ago from the days of Semmelweis 170 years ago. And yet we didn't do them. So the ambition to actually deal with MRSA came from a politician with a history degree, not from the professionals in the NHS. And that's always niggled at me. We should be ahead.
Well, food for thought there. And I have to say, I think this session and the comments from these two gentlemen, I think, are a testimony to your credibility and your integrity, both of you. I think you've given us a lot to think about over the break that's coming up now. And I also just want to say, you know, being asked to come up on stage with almost no warning and be grilled by the HSJ's patient safety correspondent is not necessarily the thing that they would want to do today. So an extra specially enthusiastic applause is worthy, I think.
Thank you.